Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone and welcome to another session in which we answer together some questions according to our free study schedule on the WhatsApp group. So today, inshallah, we are going to continue the gynecology module and the sexual health also. We have contraception and we have STDs and some surgery questions to complete what we have missed last time. So as usual, guys, I need your cooperation, please. We have the first question here. Okay. Don't worry, all the cameras are closed. Everything is all right. So just have a look on the question and tell me what you think. If a patient is worried about the possibility of thromboembolism and she wants to start the CUC, which of the following has the lowest risk of VTE? Remember when I told you this is exam question? The highest risk and the lowest risk? Okay, so I have only two of you answered. Definitely not just today. Okay, Dr. Maria and Dr. Shazia, excellent. Excellent, okay. You know the famous dinette? The famous dinette, which we use for some problems like hirsutism. It was banned in France following that because of VTE. Okay, so now the one that carries the lowest risk for VTE is the one that contain from the options here, first or second generation, yes. So Noor, Noor ethistrone is the lowest one here. Excellent. Okay, the D is like Dynogest or drospirenone and gestodine, of course, desogestrel, all are very risky. Livonor, like Livonel or the one in Mirena, is okay. Medroxyprogesterone acetate, or what we call MBA, is also safe. Yeah, okay, this is the chat box. Can you see it now? But I cannot see what you are writing, so okay, I'm going to open it from time to time. Okay, MBA is very famous. Northestrone is very famous in our practice or work. Okay, next. Very long scenario, like the last exam. So try to tell me what is the best method for her, and then we are going to see the options together. This woman is 18. Okay, and she is having one child, previous normal vaginal delivery. She came requesting contraception. She wants a reliable contraception. She is planning for a further pregnancy in 12, 18 months. Okay, her cycle is 5 to 7 days in 21 to 38 days. So a little bit hypermenorrhea, yeah, or a long period, or maybe we can say irregular. So yeah, she is having irregular, heavy, painful period. She also noted increased facial hair requiring electrolysis. She was diagnosed previously with PCO. Her weight, her height, her blood pressure. What do you think? the most suitable for her? I had to see your answers. I don't know why it's doing this. This box is the chat box, okay? And I have no idea why it's doing this. A strategy question, by the way. This session is suitable for part 1, part 2, part 3, MRCPI, because all of them share the same resource. You are aware that our main resource for contraception is FSRH guidelines, right? And you all agree that Dianet is the correct answer. I don't know why. I don't know why, really. So you are only thinking about having the increased hair and so on, but she's already removing it. And she just had a baby with a spontaneous pregnancy. Okay? The problem here mainly is the irregular heavy periods. And she still planned for pregnancy after 1 or 1.5 years. A little bit tricky. Okay, so the scenario took you to the world of Hirsutism, and I want something to help her with the Hirsutism and so on. But you totally forgot about the main problem. The main problem here is the heavy irregular periods. So something that is very reliable, something that is going to help her problem with the periods is the Mirena. Right? Why we cannot prescribe her Dianet? This is why. Because Dianet is contraindicated as she is obese. She's really obese. Depo-Provera is a good one. It is a lark and everything, but it has a problem. She can have a delay in return to fertility. And this woman wants to start the family within 1.5 years. Got it, guys? Of course, Noriday or the POP is not the best for her. It's not going to help her regarding the menstrual dysfunction, or the failure rate is really high when we compare it to other larks. Okay, if you have any problem, you can speak up now. Before we start another question, until I have something to fix this black box. Yeah, it's appearing again. Okay. So what do you think, guys? Miss Y here, who is 22, nulliparous, wants a protection. She came having unprotected sexual intercourse on day 16 of a regular 28 cycle. She is in a new relationship, had the intercourse last night. Okay, whatever, where she met him. She has not had any other episodes of unprotected intercourse this cycle. She suffers from epilepsy and takes carbamazine twice daily. Otherwise, she's well and health and no relevant family history. Before I go within choices, please, guys, tell me the only thing that this woman can have as emergency contraception. Now let's see the options. If you cannot remember, she is epileptic and on carbamazine twice daily. Okay, so we have in mind copper IUD is the best. Any hormonal contraception is not really good for her. Okay, this is like a general rule. A general rule. Livonel, however, which is not the best option. It's not the licensed option. If you do not option for the copper ID, we can have the double dose Livonel. But let me tell you guys, they should not be given if the woman is taking enzyme-inducing drugs. Okay, so we are left only with the copper IUD. Copper IUD is the only one that can be given for this lady. Okay, so whether the Livonel or the UPA, both of them cannot be given. Double dose Livonel is unlicensed option. Okay, so don't think about it first. Yes, excellent. Okay, alhamdulillah. So you all got it right, thankfully. Okay, the next one, we are doing great so far. Mrs. B, a 32-year-old para 4, just delivered a baby boy. Following unplanned pregnancy, separated and so on, she is a week postpartum, requesting a reliable form of contraception. Oh my God, she's having multiple risk factors, so let's highlight them. Family history in first-degree relative, protein acid deficiency. She herself is not having a personal VTE history. She is bottle feeding. Berberium is uncomplicated. Please remember, she is a week postpartum. Okay, the height and weight are great. I wish I have this BMI. Her blood pressure is great also. So let's see. Let's see what we have here. Regarding copper IOD, can we insert it now or not? No, no. So it is either. I'm trying my best to hide the box. My best, wallah. But it's still coming up. Okay, so it's either within the 48 hours postpartum or after how many weeks? 4 weeks, yes. So let's see. This woman can use the copper IUD now? No. Can we have the POP immediately? Advice regarding STI and condom use? I cannot see why not. So let's see other options. Commence COC 4 weeks postpartum. Advice regarding STI and condom use. Can you remind me with the risk factors, please? She's having family history of VTE. First relative. Can we have injection of Depo-Provera after 6 weeks? If I were you, I would stay away from the estrogen. Okay, I would stay away from the COCs. Okay. Yeah, she's bottle feeding. I'm trying to remind you, she's bottle feeding. Okay, and the only problem with her is the family history of VTE, if I remember well. And she's keen to start as soon as possible. Okay. We are thinking about progesterone now, right? Yes, okay. We are thinking about progesterone. Why? Why, guys? Why progesterone? Let's take it step by step. No, not because of breastfeeding. Progesterone, only pills or implant or DEMPA, all are safe with breastfeeding. This is not why I'm using progesterone. I'm talking in general. I'm searching for progesterone methods because of her risk for VTE. Right? This is number one. Number two, she wants to start as soon as possible. She is now only 1 week postpartum. Do you think for a normal, low-risk lady, you can start estrogen component contraception this very early, even if she does not have any risk factors? Okay, when it is safe to start estrogen component contraception postpartum? At least after how many weeks? Excellent, Dr. Sarah. Yes, at least 3 weeks. At least 3 weeks. If she's not breastfeeding, excellent. Yeah, I'm talking at least, generally speaking, at least 3 weeks. So I cannot by any means start the COC now. Not only because she's having risk for VTE, but also because it's very early. Okay, number two. Why I cannot start the Depo-Provera? Why in this scenario? Because they are saying injection of Depo-Provera after 6 weeks. And she wants to start immediately. She wants to start as soon as possible. Exactly. This is why. This is why. So, number one, Depo-Provera is not reliable, or the POP is not reliable. POP is really good if she took it on time. It's really good, but if she took it on time. Okay, one of the safest methods to be started very early. IOD or IOS cannot be inserted prior to 4 weeks. You got that right. Depo-Provera also is not that safe to be started this early, not like the POP. Okay, but this is not the FSRH recommendation. This is the WHO. So mainly, I'm going for the POP here because it was mentioned that we are going to start it after 6 weeks. Of course, the COC here is not her best. This woman is having protein S deficiency history. Okay, this runs in family. So we are left with the POP. You know, if the DAMPA was mentioned to be started as soon as possible, I would go for it. Because it's more reliable, of course. Okay, this lady here, she's 35, para 1+1, has recently undergone surgical management of miscarriage. It was molar pregnancy. Okay. And the HCG levels are being monitored. They are still significantly elevated. She's continuing to experience irregular vaginal bleeding following evacuation. I hope we have updated the answer for this question. I hope. But let's see. If you have read the latest update of the FSRH, can you please tell me, guys, which contraception is the only one here contraindicated for her case? The IUD. Yes, the IUD, not the COC. The latest update of the FSRH guideline is saying you can start the COC or any hormonal contraception just after evacuation. You don't have to wait for the HCG level to decline. But the one that definitely is contraindicated along with the elevation of HCG is the IUD or Mirena, of course, any intrauterine implant, any intrauterine device. Okay, not aware, we are okay. So take care of this because this update is very important. A 26-year-old woman comes to your clinic requesting emergency contraception. She's not currently in a stable relationship. She had unprotected sexual intercourse 4 days ago. She's para 1+2. Her son is 7 months, 2 terminations. On day 20, she has taken Ella1, which was 10 days ago. No significant medical or surgical history. Okay, so let me do the math. She took Ella1 10 days ago, and the unprotected sexual intercourse happened 4 days ago. I need someone to protect her. The last UPSI is 4 days ago. Can she take UPA? UPA is the Ella1. Generally speaking, if she took the UPA before, can she take UPA once more? Generally. Can you repeat Ella1 more than once in one cycle? Why not? Why? Yes, she can. Yes, she can. If she took Livonel before, she can take Livonel again. If she took UPA before, she can take UPA again. No contraindication. I'm talking in general. She took Ella1 10 days ago. So, okay, if it's possible, I can give her Ella1 again. Yes, I can. Okay, forget about she's now post-ovulation and so on. I'm just trying to stabilize some concepts. Okay, so yeah, we can repeat UPA more than once. We can repeat Livonel more than once, but we cannot give Ella1 and Livonel in the same cycle. Okay, got the rule? Now let's have a look. Okay, now she is on day 20. She is post-ovulation. The sexual intercourse happened 4 days ago, so on day 16. On day 16, yes. Now I am between giving her copper iodine or giving her another Ella1. So what do you think? Which one I should choose? So it's better the iodine, of course. But regarding the period, the unprotected intercourse was 4 days ago. Is that okay with Ella1? Yes, yes. See, I'm thinking like you in the exam. The answer is very easy, by the way. Whenever you are having emerging contraception question, the thing that should pop up in your mind first and initially is copper iodine. And then you are going to search for the reasons why you cannot prescribe copper iodine. It goes this way, not vice versa. Emergency contraception equal copper iodine. Okay, now I'm going to search within the scenario why I cannot give the copper iodine. If there is no why not, go for the copper iodine. No, it's not like this, Dr. Maria. It is not like the iodine is protective until day 19. No, it is always protective. The idea is after day 19, you should not insert copper iodine without pregnancy test. This is the idea. But before day 19, you can insert the copper iodine without a pregnancy test. Got it, guys? Don't think much about the regulations or the steps. Here, they are just telling you which one is best suited for her. What do you think? Which one is best suited for her? You tell me, what do you think? I'm with you. Okay, so Dr. Mahmoud, you still think that we should repeat the dose of Ella1? Ella1 is not the best suited for her. Number one, we are in the second half of the cycle. Okay? Number two, why not copper iodine? Tell me why not? The question is saying the one best suited for her. Copper iodine is the best suited for her. I don't care now whether it is positive or negative. I'm thinking that this one is the best suited for her. We can run the UPT. We can run the UPT and make sure. Okay? Don't be very specific in your answer like this. Because I know, guys, this is deep thinking. Deep thinking is going to make you lose marks. You know, yes, exactly. Dr. Mooley is saying if the pregnancy is positive and the patient wish to continue with the insertion of copper IOD, this is going to be like counseling. It's possible. Yes, it's possible. Okay. So the best suited for her definitely is the copper IOD. I know what you are thinking about, guys. I know what you're thinking about. But let's establish some concepts, okay? Number one, Ella1, which is great. I wish it's available in my country now. I cannot find it. This is UPA 30 milligram. Sometimes they ask you about the mechanism, by the way. It can be used more than once in a cycle. Okay, but take care if this woman is going to take UPA. Can she start any hormonal contraception the next day, or she should wait? She shall wait. Yes, she shall wait at least 5 days. Okay, so let's say the woman took the UPA and she wants to start contraception. This is what we call quick start contraception. Can I start it? Yes, but you cannot start it unless 5 days has passed. So between using the UPA and the start of a hormonal contraception, what would be your advice for her? Yeah. Avoid intercourse or use a barrier. Excellent, 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 everyone. Okay, great, great. So now, can we use the Livonel in her case? No, but because we are having like a concept, Livonel and Ella1 does not mix. Okay, excellent. So we are left with the copper IOD again. Great. This is like a legal question. A 15-year-old girl is 8 weeks pregnant and she has self-referred requesting termination of pregnancy. Self-referred means she came by herself to the early pregnancy unit. Look, Dr. Aisha, it is possible, but it's not the best. Okay, so keep it in your mind for the practical life, but not in the exam. Which is not a part of routine consultation for this question. Okay, I'm having different answers, ya Allah. Okay, she's 15. So let's take it step by step. She's 15, okay? Can she ask for termination of pregnancy or not? Is it legal or not? It is legal. Yes, it is legal. Okay. Shall we inform the child safeguarding team in her case here? No need. No need to inform the safeguarding team. When should I inform the safeguarding team? Abuse, excellent. What else? If there is any suspicion of abuse, if her boyfriend is older than her by more than how many years? 4 years, excellent. Okay, if you suspect that, it's not about competency. To inform the safeguard here, the child safeguard team, is to protect this young lady from another attack or another sexual abuse. If you are suspecting sexual abuse, how you would know that this is sexual abuse? Signs over her, or she said to you, I need to have a termination because I don't want this baby. And you have a feel that she's afraid. Okay, her tone is vibrating. She's not okay. So she has to say that she is in trouble. Okay, if this young lady was having a boyfriend who is older than her by 4 years, even if this relationship is consensual, you have to report to the child safeguard team. If this young lady here came for termination and she mentioned that she was raped, who should we inform? Which authority? The police, yes. The police. Okay, do you remember this report could be done within how many days or weeks? More than this. Yes, yes, 1 month. You can report to the police within 1 month. So please, guys, why I'm saying this? Because you are going to have some questions regarding acute presentation of a case of rape, okay? Or acute presentation for a case of FGM. And the woman is having complications. She's having complications, acute complication. Treat her first. The report can be done anytime. This is not your priority. Your priority is to save her. Okay, so here, let's get back. Which of those is not part of a routine consultation? We are not going to report to the police here. This is not a case to report to the police. In case of sexual rape, it should be done as soon as possible, but you have time. You have time. Gather your information, gather your kit tool samples and the results and everything. Okay, you have time. So I don't think that informing the parents is a part of routine consultation. This is not a routine part. Yeah, we can check for Gallic competency. We are going to check her resus status, because if she went for surgical termination, definitely she's going to need the anti-D. Okay, medical termination, there is a debate about it because she is only 10 weeks and we need some conditions to offer her anti-D if she's going for medical termination. Anyone can remember what are those conditions? If the bleeding is heavy or continuous with severe pain. Okay, but this early, she's not really in need for anti-D if she go for medical termination. Okay, guys, so you now got the right answer. This is not part of the routine counseling. Okay, you shall tell her or encourage her to tell her parents, but informing the parents is not a must for the MRCOG at least. Okay, in UK it's not a must. You shall encourage her. In Ireland it's a little bit different, not very different. It's according to the case, and they encourage you as a physician to involve the parents if needed. Okay, but in RCOG, we are just going to encourage her to tell her parents or any adult. You know why? Our target is someone can take care of her when she is using the medical termination methods, or if she's going to have a surgical termination, someone should take care of her. This is the idea, okay? So I don't know if you can see it. Have a look and tell me. I'm getting only 3 answers. This one should be very easy. Come on. The patient left the combined bill because she had migraine with aura. Okay, migraine with aura is category 4 for COCs. She's now using the diaphragm and she's looking for something reliable. Which lark here is not correct? Yeah, my mistake. Okay. Now apparent. By the way, we have an update regarding Myrina. Myrina now is effective for how many years? I wish it was 10, but it's not 10. Myrina now is licensed for contraception for 8 years. 8 years. So I shall send you this update to the group. Let's go through the options one by one because I have a feeling that this question is not updated, of course. So Myrina here is effective according to the latest update for 8 years. Nexaplanon, the implant, is effective for how many years? As far as I know, it's only 3 years. Yes. The copper IOD is effective for 10 years. This is correct. The multi-load copper coil is effective for 5 years. I think this is also correct. Depo-Provera injection is effective for 13 weeks. And I have something to say about this here. So please pay attention with me. Okay, Depo-Provera, it's a very unique one. Okay, DEMPA. DEMPA injection, guys, is the only one that if the patient came late for her injection until week 14, she's safe. So let's suppose that the woman next injection was in day, you need a pen, okay, was in day 20, no, not 20, let's make it easier, 2, okay? The next injection is in April the 2nd. April the 2nd. This is the timing for her injection. Okay, she came to you on day, she came to you on day 8. April the 8th. Are you going to prescribe extra contraception or a precaution? Or if unprotected sexual intercourse happens, she needs emergency contraception? No need. Yes, excellent. No need. Why? Because it is effective for 13 weeks and the woman is safe up to 14 weeks from her last injection. So this woman here, her date for the next injection is April 2 or April the 2nd. She is safe up to day 9. If she came after day 9 and she had unprotected sexual intercourse, give emergency contraception. If she came after day 9 for her injection, she will take the injection, but what would be the extra precaution? Abstain sex or use barriers for the upcoming 7 days. Okay, got it? Got it, guys? Everyone got this one? Repeat, okay. So the woman is having DEMPA. She is going to be protected, not up to 13 weeks, up to 14 weeks. In ideal world, in ideal universe, she should have her next injection after 13 weeks. If she came late for another week, she's okay, she's safe. No need for extra precaution, no need for emergency contraception, nothing. But if she passed the 14 weeks, she's going to need emergency contraception in case she had sexual intercourse last night, And she's going to need also extra precaution, which is barrier for the upcoming 7 days, or abstain of sex for the upcoming 7 days. Okay, this is something very unique for DEMPA. Not like the COC and PUPs. Okay, great, alhamdulillah. Let's see this one. I can feel that you are okay continuing with contraception for today. And I'm okay too. So this woman here, she requests contraception. She is having maternal aunt had DVT, maternal aunt, okay, and she's on warfarin. She's worried that if she take the hormonal contraception, she will also develop the DVT. Okay, so this is the theoretical question. You can read quickly and tell me which one you think is incorrect. Forget about the options. I don't like them. Forget about them. If this woman really need to have a combined hormonal method, okay, or she want to start HRT for whatever reason, which route is the best for her? Oral, transdermal, vaginal, transdermal. Thank you. This is what I want to hear. Yes, the transdermal route. Okay, what about D? There is a little or no data to suggest that there is an increased risk of VTE with oral or injectable progesterone-only contraceptive methods. I don't know, but I suspect this one. Okay, the correct answer is, which is incorrect, the risk of VTE increased with the number of years of usage. Actually, it's going to be not the same. It's going to increase compared to non-users, but it's not increasing through the years. It's not increasing through the years. Okay? On contrary, the risk for VTE is the highest in the 4 months following initiation of COC. And then it's going to decline over the next year. And then it's going to plateau. Option A. Option A. Observational studies have reported that transdermal patch has somewhat similar level of VTE risk to combined oral contraceptives containing second-generation progestogens. Oh, yes, containing second-generation progestogens. Okay, but still, if you want to prescribe something that is safer than the oral method, it would be the transdermal method, of course. Take care also, guys, that routine testing for thrombophilia is not recommended. Routine testing for thrombophilia is not recommended. Yeah, it does, by the way. It does, but they are comparing it with the COC containing second generation progestogens. When it's the second generation progestogens, it's almost the same risk. So here, guys, a couple have come to your clinic requesting sterilization. After going through the risk and benefits of the procedure, they opted for vasectomy. Which of the following should not be taken into consideration during vasectomy? Where's my guys? Where is my guys? I highlighted when should we do the post-operative semen analysis. When should we do it? 12 weeks. Yes, 12 weeks or 3 months. Excellent. If you find motile sperm in the fresh semen sample, 3 months post-procedure, are you going to consider vasectomy a failure? No? No or yes? Motile, 3 months. I just want to jump and give you a hug, Dr. Nabila. So after how many months we are going to consider the procedure a failure or a failed procedure? If you find motile sperm in the fresh sample. Can you remember how many months? Let's remember. Okay, so Dr. Maria also need a hug. I love you guys when you are studying hard. Okay, some numbers. I'm not someone who like numbers or like memorizing numbers, but here those numbers are very important. Motile sperm, if you find them in the fresh semen sample 3 months post the procedure, the vasectomy is considered to be a failure. This is the incorrect one. The incorrect one, because correct statement is if motile sperms are observed 7 months post vasectomy, that procedure should be considered a failure. Okay, again, when we do the post vasectomy semen analysis after 3 months, okay, you may find immotile sperm. This is okay. This is accepted, okay, and expected also. When you see clearance from the sample, you can give the couples carte blanche or white card that they can stop any kind of contraception and they can live their life happily ever after. When you see clearance means sperm count less than 100,000, non-motile, of course, non-motile. Okay? But sometimes they are going to come to you with some motile sperms. Okay, after 3 months, I'm not going to say that the procedure is a failure. But if you observe them 7 months post vasectomy, this is complete failure. This is a complete failure because we are expecting to see a complete adhesion in the vas deferens by 7 months. So how a motile sperm would come out? Oligo and non-motile, this is not a complete clearance. I need this number, not just oligo. I need this number, less than 100,000 per milli. Oligo is a very wide term. It's just like what's mentioned in the guideline. Let's be strict to the guideline. Okay, this young lady here, she's 27. She is requesting DEMPA. She wants to know about the non-contraceptive benefits and risks of injectable progestrogens. Which one is incorrect? Okay. This is very important, by the way, in the exam. Take care. They are asking about correct or incorrect, best, next. This is the incorrect one. So most of you agree that it's C, and you are right. Yes, you are right. DEMPA is very good option for women who are having VTE or a previous history of VTE. Okay, this one in particular, it's only 2, category 2. If the woman is having a VTE with a previous history after immobilization, this is 2. So 2 means having DEMPA is better than not having them. If you remember, we love this method for anemic patients because it's going to cause them amenorrhea, right? And we also like it for systemic lupus patient, okay? But take care if this woman is having extra causes for VTE. Like, for example, if the woman is systemic lupus and she's having antiphospholipid antibody syndrome, this is not going to be the best for her. Good for endometriosis, definitely, for the same reason, amenorrhea. And good for epilepsy. Remember when I told you guys that, sorry, the sickle cell crisis, I'm sorry. Sickle cell crisis, and also for epilepsy, by the way. Women with sickle cell disease are going to notice decrease in pain. And also for epilepsy, they are going to have, less risk for episodes. Okay. So who knows this one? Where in the fallopian tubes the micro insert should be placed? the ampulla, the infundibulum, intraluminal, intramyometrial, the isthmus. I hate this word, the isthmus, because it's very long. It's a very long place. The isthmus is the part inside the myometrial or the intramural part and up to here. All of this is the isthmus. We should insert the microinsert in the narrowest place of the fallopian tube. The narrowest place of the fallopian tube is the interstitial part or the intramural part, which is the intramyometrial part. Guys, look, this is like by far the most common mistake I have ever seen for the 3 parts, part 1, part 2, and part 3. I have no idea who told you that asthmic part of the fallopian tube is the narrowest part. Wallah al-Azim, it's not the narrowest part. The narrowest part is here. It's here. Let me make it bulky. It's here. Intramural. Intramural. The isthmus is here. Then the ampulla, then the infundibulum. But the narrowest one is the intramyometrial or intramural or interstitial. By the way, this is a question for every part, even for the MRCPI. Okay, when you are going to arrange the follow-up ultrasound to confirm the occlusion of the fallopian tubes. Three months, just like the male. Yes, 3 months, just like the male. Okay. You know that microinserts are not licensed in the UK anymore. I don't know if they changed this or not. Intramural is just like intramyometrial. And this is a strategy question, by the way. Okay, let me show you something. Okay, can you see the position? Where it is? Almost inside the uterus. Just the ostia of the tube. The very, very first part of the tube. Let me remove the black box. You can see it now, right? See? See where it is? The isthmus is from here to here. This is the isthmus, or the isthmic part of the fallopian tube. But we are dealing with the intramyometrial part or the intramural part. It's left there until it's going to develop fibrous tissue and block the entrance of the tube. Okay? Now, someone please remind me, if we are using the fishy clips, the fishy clips is made of what? Because this is a recall. Titanium, okay, but it's all titanium All of it is titanium. The inner part of the clip is made of what? The inner part, the one that's going to compress over the tube. Silicone, excellent, because this is a recall, guys, and it was like titanium plus nickel, titanium plus copper, titanium with a silicone inner part, so it's titanium from the outside because it's inert, and from the inside it's silicone to press over the tubes and remain like it is. It has a memory. Excellent. Okay. Now this young lady here, you are going to prescribe combined transdermal patches for a 15-year-old girl with cerebral palsy. Yeah, I love the Stog article, Contraceptions in Disabled Population. And she is unable to cope with her periods. For the combined transdermal patches to achieve the same effect as continuous oral contraceptive pill, for how long the patches should be applied serially for? We call it tricyclic method. I gave you the answer. Come on. We call it tricyclic method. Tricycle means 3 cycle, not 3 weeks. I wish the chat box is apparent in the recording. Wallah, I wish. I'm going to do something to make it apparent in the recording. Tricyclic means 3 cycles. 3 cycles, not 3 weeks. So it's 9 weeks followed by 7-day withdrawal period. And let me tell you, this is the best regimen for disabled or mentally ill or special situation girls, or anything that is going to make the lady immobile or cannot take care of herself. Okay, this is the best ever. But take care, please. If the young lady is obese and she is permanently immobilized, think twice about giving her hormonal contraception. Okay? However, in the exam, if they are asking you what would be the best regimen for such ladies, the tricyclic COCs, which is the best for them for controlling the HMB. In non-hormonal methods, this would be tranexamic acid. For hormonal methods, continuous COC. Then the alternative is Mirena. Okay, you can find this in 2 TOG articles. One of them is called Contraception in Disabled, and the other one is heavy menstrual bleeding in adolescents. Okay, so we have 2 ways. We can apply the patches or give the COC. Of course, the patches here is preferable for her because she cannot take it orally, or for some reason she cannot cope with the oral drug. So patches serially for 9 weeks with 7-day withdrawal period, or continuously until breakthrough bleeding. Okay, take care of those with low body weight or taking enzyme inhibiting anti-epileptic drugs. Okay, because they are going to affect the dose of the patches. And take care also in the obese patients, because they are going to be at risk for VTE. So you are weighing the risk and benefits. But for the exam, it's very easy to make your mind when the scenario is very general and they are asking you about the preferred method for a woman with disability. Okay, this woman is 47. She has been referred due to amenorrhea. She's not taking any regular medication, including hormonal contraception. Alhamdulillah, alhamdulillah. She stopped having periods 1 year ago. So no contraceptions and amenorrhea for 1 year. She tells you she uses condoms for contraception and asks if she still needs to use these contraceptions or she shall stop them. Is in one word. Okay, mashallah, mashallah, you got it all right. This woman is menopausal or not? Not yet. Yes, not yet, because she's less than 50. Excellent. So I need to see amenorrhea for 2 years. After 50, only 1 year of amenorrhea is enough to diagnose menopause. So this woman should continue using any barrier method, or even if she wants to have POP or any progesterone method, she can for another 1 year. No, Dr. Shazia, Dr. Buana, not for 2 years. She's already having amenorrhea for 1 year. So we still want to make sure or make her safe for another 1 year. Okay, if this woman, guys, I know I'm giving myself headache, but anyway, if this woman was taking COCs and she told you, I have stopped having period 1 year ago, please can you give me the correct answer from those? She told you, I'm using COC and I stopped right now using the COC, okay, and I have been amenorrheic for 1 year. What would be the best answer? I would write it down so that you won't say I didn't get it. She was using COC, stop it, shift to condoms, okay, amenorrhea for 1 year. Choose the right answer from the options, please. You can add whatever you want to the answers. The same, 47. She just stopped the COC now because she is amenorrheic for 1 year. No FSH level. They just bring you the case like this. Shall I write it down in total? 47 was using COCs, just stop it and shifted to condoms after being amenorrheic for 1 year. What would be your advice for her? I would add something here also. Continue using condoms and stop them after 2 years of amenorrhea? This would be the best answer. Continue using condoms and stop after 2 years of amenorrhea. You agree or you don't agree? You can disagree with me. It's your right. So first I need to stop the COC, and she just did. I'm not going to count the past amenorrheic year. I'm not going to count it. I'm going to count 2 years after stoppage of COC. You got what I want to say? Stop after 2 years of amenorrhea after stopping the COC. Okay. Which dog article? This is perimenopausal. Contraception in or issues around menopause, something like this. I can give you all of them, no problem. Oh yeah, we have it here. Lucky us, we have it here. Okay, this is our summary. So just let me show you my favorite slide. My favorite slide is which one? Yes, this one. This one is my favorite. Let me remove all of this. Okay, you can take a screenshot if you want. Okay, for those who are under 50, okay, and they do not use hormonal methods, we shall continue the contraception for 2 years of amenorrhea. Okay, this is the most important part. If she is using COC, she shall stop it, and we shall wait for 2 years of amenorrhea. What if she wants to know now, right now, whether she is menopausal or not? Well, this could be easy if she is using other contraception methods, not COC. COC is having a very good negative feedback on the pituitary. So the test is not going to be reliable. However, the authors of the talk article were saying that you can stop the COC 2 weeks prior to testing, but the evidence is limited. The evidence is limited. Again, the black box. Okay, it's not here now, alhamdulillah. For those who are having progesterones like DEMPA, okay, especially DEMPA, it takes long time to remove the negative feedback. So it should be stopped at least 1 year before taking the FSH. I don't want you to remember this. I don't want you to remember this. Just remember, she has to stop the hormonal contraception, okay? Especially COC and DEMPA. And then, after 2 years of amenorrhea, now we can call her menopause. Okay? For those above 50, and they are already using POP or implant or Mirena or any IOS, and she wants to continue using them, yeah, she can. She can. Exactly. By far until 55, or 1 year after recording two FSH levels more than 30. But you can put in your mind until 55. Yes, exactly. Until 55. And they are going to be very good if she's going to start HRT. Right? She's already used to taking the POP or the implant or the IUS. So now if she wants to start estrogen HRT, she can easily. Okay, sorry if I conflicted you. Oh, I hate percentages. Okay. So this woman is perimenopausal and she started sequential HRT. She tells you she is in a new relationship and asks if the HRT will be contraceptive. So yes or no? HRT is contraceptive? No, no. This is why in perimenopausal women or younger women who are having POI and she don't want to get pregnant and she need HRT, what would be the best method for her to achieve contraception and the deficiency of estrogen? COC. Yes, exactly. So by how many percentage the cyclic HRT is going to inhibit ovulation? Only 40%. So she is still risky to get pregnant, of course. Okay, yeah, good one. You are reviewing 50-year-old woman. She is currently taking microgynon, but has been experiencing hot flushes recently. She feels this is the menopause and asks your advice about blood test for menopause and if you can stop contraception. Dr. Shumaila, yes, it is the best for them. If they want to abolish conceiving, if she wants something for contraception, if she does not want any kids, HRT is not contraceptive. So she's going to take COC. COC is going to play two rules. The one is contraception, the other is giving her the estrogen she needs. Okay, she is 50, just 50. Okay, and she is taking a POP. Oh, this is a typical exam question. The most appropriate advice. The woman is 50 and she's having menopausal symptoms. I still need something to diagnose her as a menopausal. I still need amenorrhea for 1 year to diagnose her as menopausal. Or I can check the FSH because she is just 50. She's not above 50. And she wants to stop the contraception. Yeah, and this is a typical exam question. The cutoff for menopause, diagnosing menopause according to the FSRH, a nice guideline, is 30. on 2 occasions, 4 to 6 weeks apart. Shall we stop the POP or not? To have the test, should we stop the POP? If she is taking POP, no, we don't need to stop. But if she is using COC, she should stop it. So let's have a quick look. Okay. So as you can see, they are telling us FSH is unreliable if the woman is taking combined hormonal contraception. So number one, if the patient remains on contraception, she should ideally be switched, as the combined one is not recommended beyond the age of 50. Yes, dear, it's a CUC. It wouldn't be advised to stop the contraception altogether until menopause is confirmed. So what shall I do? I need to switch it. This woman needs to be switched to a progesterone or to a barrier method. Wait until she is amenorrheic for 1 year, and then she can stop everything, right? So the FSH is suppressed by the COC, and it's not reliable. Remember when I showed you here? This one. Yeah, the evidence is limited, but this is what's between our hands. So COC should be stopped 2 weeks before the testing. And if the first reading is consistent with menopause, you are going to take another one. If 2 readings are more than 30, then the patient should be advised to continue contraception for 1 year before stopping, because we still are not 100% sure she is amenorrheic because of the negative feedback of the COC or because she's really menopausal. So C here is the correct answer. Have a look on the question. Take your time. Tell me, what do you think? What we are doing here is not the best. Okay? What we are doing here is not the best. I'm repeating. The best is stop the COC, switch to barrier methods or a progesterone method. Okay? She can continue on the progesterone method until 55, or she can have the barrier method and get 1 year of amenorrhea. She is 50 already, and she can stop whatever contraception on earth. This would be the ideal counseling. But if the woman is eager to stop, let me tell you, she's not going to stop the COC until 1 year. She's going to continue. Sorry, not the COC, at least POP or any kind of contraception. Any kind of contraception for 1 year. Because we are not sure that she is really menopausal. So in the imperfect case where she is having high FSH reading, she still is going to be advised to continue contraception for another 1 year. I hope you got what I'm talking about. And we are going to take this question as the last one. if less than 50 and she is having high FSH more than 30, she should use the contraception for 2 years or not? No, if she is less than 50, was she using COC or not? If she is not using COC, this woman is menopausal. A woman less than 50 not using contraceptions and she is having 2 tests of FSH more than 30, this woman is menopausal. But if she is using hormonal contraception, you need to have 2 years of amenorrhea before stopping anything. Don't depend on the FSH. So you guys have made your mind about this one? The only correct answer is Gynefix is currently the only frameless IUD licensed in the UK. The most important line for me here is this one. This line is not true. IUD does not increase the risk of ectopic pregnancy. But if the woman gets pregnant while having IUD, this pregnancy is more risky to be ectopic. You got the difference? Again, I can repeat it. I can repeat it. IUD itself does not increase the risk of ectopic pregnancy. However, if the woman got pregnant while she is having IUD in situ, the risk for having ectopic pregnancy is more. Because the implantation is not going to be intrauterine. Okay, and there is a huge difference between the two lines. Does IUD increase the risk of intrauterine infections or pelvic infections? No. But if the woman is having PID and she is having IUD in situ, she can get worse. And okay, if a woman is having PID and she is having IUD in situ, are you going to counsel her about removing the IUD or not? Definitely no, but if she is still unresponsive to treatment, exactly, if she is not improving or unresponsive to treatment, more than 24 hours. 3 days. Yeah, 3 days. You shall consider removing it. Those are the most important lines for me today. And I'm going to send you this file. Okay, guys? I don't think the upcoming questions are, yeah, this is the last one. And it's already a theoretical one. So thank you so much, Wallahi. I enjoy spending time with you. I don't know how I'm so optimistic that I thought we would finish everything today, but it's okay. We are together. We can have more meetings, inshallah. Thank you, thank you, thank you so much. Thank you for attending. Yes, yes, dear, I'm with you. Yes, Dr. Wajih, I'm with you. Okay, not all of them because they are huge, but at least you have to go through post-pregnancy or contraception after pregnancy. This is very important. And let's say have a quick look on the side effects of each method, a quick look, and the incorrect use. So if I have to choose one or two guidelines from the FSRH, I would choose for you contraceptions after pregnancy and management of incorrect use. The rest you can go through, as I'm telling you, side effects of the COC, side effects of the PUPs. Mostly they are similar, but just to have an idea about the latest evidence. Which one is really going to cause you weight gain? Which one is really connected to the decrease of bone density? That's it. And I have already sent it to the group, to the WhatsApp group. I can send it again, no problem. So look here, guys, I'm going to open Google for you, show you something before we finish. Okay, so if you write down FSRH guidelines, there are many. There are so many. Okay, so each specific method have its own guideline. And also we have the UKMEC, which is a crucial one. This is a crucial one. I want you to know which one is UKMEC for. Totally contraindicated. So if we open here, they are totally free. We have the emergency contraception, very important, but the TOG is much better, concised. Okay, so you can go for emergency contraception and IOD TOG article if you want. Forget about switching or starting methods. It's going to give you a headache. Contraception for a specific population like perimenopausal and special needs, and they are also TOG articles. Where the other one? Where is the other one? Method specific. Let's see if it's here. No, it's not here. Quick start, I think. No, not this one. There is a someone called contraception after pregnancy. I'm going to send it to you. I'm going to send it to you. Easier. I have it. I have it already here. Okay, so you don't have to get lost between the resources. Okay, I'm going to send it to you. I have it here somewhere. Okay, thank you so much, guys, for attending. See you next time, inshallah. Don't forget me from your prayers. Assalamu alaikum.